the big the big part that really came out as far as the remote care side of things is the expansion of the RPM codes. So this is the biggest expansion of remote patient monitoring on the CMS side, really since their release or soon after, right, in 2019. So a bit about the sort of the timeline as to how we got here today, right? So RPM introduced really, so there was RPM before 2019. The current regime and billing sort of criteria that we use today came about in 2019, and really is what it spurred, adoption of the codes. The idea there was they were trying to build a code to bill for RPM that was really expansive, right? So you have all these codes for Holters and MCTs and other things where they're specific to condition and they're specific to device. And because of that, you can get really nuanced with the reimbursement and the criteria. When is a billable, Holter, right, study? It can be very specific. For RPM, they were trying to be more broad because they were trying, one, to have innovation. They didn't know exactly where it'd be used. And two, they were just trying to keep it relatively open so they didn't have to make a code for every single permutation of monitoring. So they decided to do 16 measurement days or days of measurement transmitted per month as sort of the minimum billable threshold. And that was really just balancing that universal code for all those possible conditions with having it be reimbursable and having folks have incentive to do these codes, right? That said, that 16 measurement days was sort of an all or nothing threshold where there was this arbitrary amount of measurements that was not one-to-one with sort of clinical validity of what you needed and how many measurements you needed, right? So you suddenly had this barrier where for lots of different modalities, 16 measurement days wasn't needed clinically. And you had a push for patients to take those measurements anyway, because to have a billable code, for better or worse, it's a business as well as practicing medicine, right? You'd have this push for people to take more measurements than they strictly needed. So for years, since the 2019 release of the codes, digital health stakeholders, providers, we've been advocating for more flexibility to the AMA and to CMS. And really, it was rejected quite a few times by the AMA to do a smaller amount of measurement days required. In 2024, September of last year, the CPT meeting from the AMA came out and said, okay, we're going to establish new codes to allow for less than 16 days of measurement transmission per month. And we now know what that code is. It's 99445, which slightly confusing when the 16-day plus one is 99454, and this is 99455. I'm going to mess it up so many times. I apologize in advance. 99445. So what does that mean? New code, you have to have a minimum now of 2 transmissions days, right? 2 measurement days in the 30-day period. So it went from 16. Now you have a code that can do 2 to 15. That code reimburses the same amount as the 16 reading code. Why does it reimburse the same amount? Partially because it's not like you're giving the patient the device for only 2 days, right? The costs that are underlying the code are pretty similar, whether it be the patient has it for 30 days and uses it twice versus if they use it 16 times. So what does this do? It enables more flexible, tailored approaches to RPM and allows for more conditions that you didn't need 16 measurements for, realistically. So this expands out the use of RPM significantly. We did a bit of research, even just internally with our own customers, as to sort of what percentage will this increase sort of billable patients and patients hitting the threshold. And even without doing anything else, it's about 20%, a little under, a little over, depending on the place, as far as patients who were at 14 measurements and didn't get billed for a specific, month. So definitely a huge boon to reimbursement, but also a huge boon just to having more flexibility with patients and who can benefit from these services. On top of the measurement, slightly less, also important, albeit I think slightly less impactful, is so remember, old regime, you had to have 60 measurements, and then it was 20-minute increments of care management time related to RPM. So now there's a new code that allows 10 to 20 minutes of management time for RPM. So unlike the measurement code, which is reimbursing the same, whether it's 2 measurements or 16 measurements, this code, because it's half the time spent, is reimburses at half the amount of the 20-minute code. So, I mean, makes sense. Probably, it's a reasonable way to do it. So reimbursement is lower, but you're spending 10 minutes to 20 minutes instead of 20 minutes to 40 minutes. So between the two, a lot more flexibility in these programs, and then allowing them to expand out to other modalities, right? So I buried the lead on this slide a little bit, but the idea here is 2 to 15 monitoring days. So this allows you to, as an example, maybe. So I should step back for a second. The important part here is CMS said really explicitly when they were promulgating the new rule that this doesn't mean that every patient should take only 2 measurements. Like, this means that we are broadening the restriction under the assumption and the obligation for providers to tell their patients to take measurements a clinically valid amount of times. So if you have every single patient taking their readings twice, because let's be honest, 2 measurements a month is pretty low for most conditions that exist, right? That these things are being done for. So with that, the idea here is you determine the clinically relevant amount of data, you have the patient do that, and sort of off you go to the races. As an example here, let's say you want the patient to, as for like example of why this could be clinically changed over time, but also how to do like clinically relevant numbers and goals for the patient. Maybe you do want them to measure their blood pressure daily during like initial titration of antihypertensives, right? But then twice a week, once they're controlled, when you're shifting a program towards chronic care management and diet and exercise and things like that. So you have the flexibility, but still do it in good faith. Make sure you're not just doing 2 measurements for every single patient, no matter what. The 10-minute thing also allows for sort of briefer, but also still clinically impactful interactions, right? So no longer do you have to have exactly 20 minutes or more. Let's say you're doing like weight loss or weight loss is actually a good one, where maybe you're just doing check-ins to see, you prescribe GLP-1s and you're calling and doing a 10-minute check-in about side effects or how much they're losing, things like that. This gives you the flexibility to basically get paid pro rata dollar for dollar, right? It's not like you get paid the same amount, but dollar for dollar, for 10 minutes to 20 minutes instead of just 20 or over. There's still this barrier now at 10 minutes, but that's, a relatively reasonable barrier for an initial sort of, critical mass to build these things. Final takeaway here is this really allows new clinical scenarios, right? So a lot of medical weight loss GLP-1, having somebody weigh themselves 16 days a month was, 1, not needed, but 2, almost maybe like too much to be, it could be almost detrimental, right? There's also these other devices like spirometry, where you have to blow into a spirometer, where it's super clinically beneficial to have that data, but it's also not like a light lift to take the measurements. So having a patient do it 16 times a month was a lot to ask, where you have, peak flow spirometry readings once a week. Great. You're doing something with bronchiectasis and, with antibiotic titration, things like that, or antibiotic use, whatever it might be. The idea here is for these devices that are harder to use, it's just a lower amount of barrier for patients to be able to do these things. This is a comparison that we did for one of our clients. It's a 522 patient RPM program that is doing longitudinal hypertension diabetes monitoring. So we wanted to see, without anything changed, how would this affect a running program at the end of this year? Actually, this is probably the middle of this year, with no changes to workflow. How would this, increase the amount of revenue for patients that weren't hitting either time or device readings? And it ends up being about 20%, which not bupkis, right? Everyone has some patients who take 14 readings, or you really only spent 12 minutes on the phone with them. So this increases reimbursement for those cases where that's the case.